Thank you. My idea is what we know now on ovarian physiology. Do we have new information which is clinically relevant to change the standard protocols that we have been using so far for the last 40 years? And my answer is yes. We know the concept of FSH window exists, but can be now, we can manipulate this FSH window better than before, because we know that during the follicular phase, during the classical FSH window, there was a different wave of follicular recruitment that there were directly related to this FSH window. The classical way, usually in the follicular phase, there were several waves of follicular growth that follow the pathway normally: selection, dominance, to have a single dominant follicle, and ovulation. But we now know that there are also minor recruitment waves which dominant normally is not produced. However, most women present these minor follicular recruitment waves during the follicular phase, and also one or two during the luteal phase that normally are not, they do not reach full maturation and ovulation. But taking advantage of these multiple recruitment waves in follicular and the luteal phase, we can widen the FSH window by giving extra and a different chronology of FSH administration, and we can rescue these follicles from atresia to reach full maturation by starting stimulation in the luteal phase of the ovarian cycles. The need for GnRH antagonist co-treatment in this luteal phase ovarian stimulation is still a matter for discussion, and we will come back to this point at the end of my presentation. The first thing and most important thing we have to consider is the ovarian response to ovarian stimulation, and we all agree that there are some credos in reproductive medicine. One is the more oocytes you get from an oocyte pickup, the higher the clinical pregnancy and live birth rates will be. And this is absolutely true up to, let's say, 15, 20 oocytes. Over 20, you do not increase the pregnancy rate, and you will increase, for sure, the risk of hyperresponse and the risk of OHSS. This is why so far we had three different categories. The low responders, according to the ESRE criteria, those patients producing a maximum of 3 oocytes. The high responders, patients producing 15 oocytes per pickup, and the group in between was considered as normal responders. But Nikos Politsos and Session Kara have subclassified this group of normal responders in 2 subgroups. The optimal response is from 10 to 15 oocytes, and the suboptimal response, those patients between the optimal and the poor response, those patients producing 4 to 9 oocytes. The classical low responders in our hospital, we consider the 3 markers of ovarian reserve, apart from age, of course: antral follicle count, AMH, and FSH. And we consider in our own material as a poor responders or low responders those patients between the 10th percentile compared to the response of the rest of the patients. And the cutoff values in our own material were 7 follicles in the antral follicle count, AMH below 0.27, and FSH above 8 on day 3, day 5 of the follicular phase. Those patients not fulfilling this criteria were considered as supposed normal responders. And we agree that if we take into consideration the age of the patients, the anti-Mullerian levels, and antral follicle count, and we combine these three markers, we will succeed in predicting the response of the patients. When we will be close to 1, the possibility of an optimal response will be very high or high. If we are down to close to 0, the possibility of an optimal response will be low or very low. And the difference between optimal and suboptimal is very important, because if we modify the graph published by Sankara some years ago, in which they present the possibility of live birth, the predictive live birth rate according to the age of the patient and according to the size of the cohort of oocyte retrieved, if we increase, let's say, 1 or 2 oocytes by improving the results in this group of suboptimal responders, you will see how we can increase the live birth rate by 10%, by 9%, by 7%, by 5%. So we have to focus our attention on this group of suboptimal responders. And we have analyzed our own material according to, here we have the group of patients, poor responders, maximum 3 oocyte retrieve. Here, hyper responders, more than 15 oocytes. And in between, the optimal responders from 10 to 15 and the suboptimal from 4 to 9. And we will see that there are significant difference among these 4 groups as far as age, antral follicle count, AMH levels, days of stimulation, gonadotropin requirement, number of oocytes, and embryos transferred. And if we focus and we compare the difference between optimal and suboptimal, you will see that the 2 markers of AMH and antral follicle count were, apart from age, were sufficient to clearly predict significant differences between these 2 groups. So by using these 2 markers, you can predict those patients that will present a suboptimal response, and maybe you should use another protocol, or you will introduce some new strategy in order to pass patients from this group to this one. And we consider the markers for us in our center, according to our own material, for a suboptimal response, 4 to 9 oocytes were an anti-Mullerian hormone of lower than 0.9 nanograms and less than 11 antral follicle count. If we focus on bad response or poor response, is less than 4 oocytes, these values become even worse. For anti-Mullerian is lower than 0.4 nanograms per ml, and antral follicle counts of less than 7 follicles. It's important to identify your patient, and according to her ovarian reserve, to establish, to tailor, to individualize the ovarian stimulation protocol. And look how easy it is to identify different clinical outcomes. For example, the freezing rate, the possibility of freezing surplus embryos, how different is in the group of suboptimal was 34 in our own material, 0.5%, compared to 69.5% in the group of optimal response. And this difference is clearly significant, and this translates in, here we compare the clinical outcomes, pregnancy rate, no difference between the 2 groups, miscarriage rate, no difference, live birth rate per fresh cycle, no difference, but if we consider the cumulative live birth rate, so fresh plus frozen cycles, here you have a significant improvement in the group of patients with optimal response. So we have work to do to change the situation of these patients and try to put them in the group of optimal response. How can we obtain better results with ovarian stimulation. The first point is to identify your patient. And in this graph published by Nelson some years ago, by using antral follicle count and AMH, you can select the protocol to be applied. So the better values of antral follicle count and of anti-mullerian hormone, the higher risk of hyper-response you will have, and you will suggest this patient to be treated with an antagonist cycle and with a bolus of agonists for ovulation induction. Normal patients being supposed to normally respond, you can use agonist or antagonist protocol, and those patients in which you predict a poor response, it's better to use a short protocol, a flare agonist protocol, or in the end, if there is no chance, you have to suggest them to switch to oocyte donation. Again, the combination of a depot gonadotropin preparation, this is the protocol that we use in our center. We pre-treat the patient with a pill. We start the stimulation on the first or the second day of the cycle. We administer a dose of Elomba, of corifolitrompin alpha, and after 6 days, we start the daily administration of a GnRH antagonist, and we daily adapt the extra doses of gonadotropin needed to reach a good follicular maturation. And here we compare two groups of patients being treated with Elomba. Group A were patients with a previous suboptimal response, and Group B were patients in which we were aware of probable poor response because of their low ovarian reserve. And as you can see here, by using this combination of depot gonadotropin preparation, Elomba, plus daily doses of gonadotropins and antagonists, on average, we obtain 10 oocytes. So we succeed in putting these patients in the category of optimal responders. Another issue for discussion is the steroid pretreatment in ART, and this can be accomplished by giving these patients OCs, estrogens, progestins, and androgens. The use of OCs or estrogens is mainly based on the comfort of programming the cycles. The use of androgens seems to be useful to improve the response of poor responders by increasing the responsiveness of ovarian follicles to FSH and the number of growing follicles. The use of OCs has, a part of the advantage of scheduling the cycles, you have the advantage of abolishing or avoiding the heterogeneity of the growth of different antral follicle sizes. But this is a hot issue to discuss, and several publications in the literature have focused on this to-pill or not to-pill in GnRH antagonist cycles. And this is a recent publication. In some of the publications, as you will see, are against the use of OCs as a pretreatment. Some are in favor. So we have here an issue to discuss. What about what I mentioned in my introduction, the luteal phase ovarian stimulation? And this is the rationale of this strategy is that the high luteal progesterone levels in blood have a negative feedback on the pituitary and prevents a premature LH surge. This is why it's not clear that these patients need a GnRH antagonist suppression. The second point is that the estradiol produced by corpus luteum might enhance the sensitivity of granulosa cells to FSH by increasing the number of FSH receptors, and androgen production induced by this periovulatory or luteal LH secretion may increase the sensibility to FSH upregulation of the FSH receptor expression in granulosa cells. These protocols of luteal phase stimulation have been used in 3 different clinical scenarios. The first one was for patients suffering from malignancy requiring fertility preservation, in which you have to start follicular stimulation anytime during the cycle. And we have a first publication by Michael von Wolf. He showed that there were no difference. Another strategy is being used in China, what they call the Shanghai protocol. They use as a routine, they have thousands of cases being treated with luteal phase ovarian stimulation, embryo freezing, and deferred embryo transfer. And we have also used, and we have published, as you will see, in an oocyte donor setting. By using this protocol, ovarian stimulation can be totally disconnected from the cycling phases of endogenous gonadotropins without any detrimental consequences as far as pregnancy rate, as long as no fresh embryo transfer will take place. And we have published the use of luteal phase stimulation in oocyte donors, and we published a group of 9 donors in which they had a first ovarian stimulation cycle, start classically on day 2 of the cycle, and the same donor had a second ovarian stimulation cycle for oocyte donation starting on day 15. And we have analyzed the results obtained in the corresponding recipients of the vitrified oocytes. This is the graph of this study, 9 donors, and day 2 stimulation, and all the oocytes vitrified and transferred to recipient afterwards, and the same donor, a second cycle starting on day 15. And we have not observed any difference in the clinical and live birth rates obtained in the corresponding recipient. So the competence of oocytes obtained in luteal phase was similar to the quality of those oocytes obtained stimulating in day 2 of the cycle. The safety of this luteal phase stimulation seems good, and these are data from the Chinese group, in which, as you will see here, they compare babies born after 2,000 IVF cycles with IVF and ICSI. Treatments were conducted after luteal phase stimulation, practically 587 cycles, agonist protocol, 1,200, and mild ovarian stimulation. No difference in the rate of fetal abnormality among these 3 protocols. And finally, and you will see in this conference several presentations on the strategy of freeze all embryos and deferred embryo transfer. And it's very interesting, this publication by Christophe Broquil from the Brussels group, in which he presented the strategy they are following to have this OHSS-free clinic, starting GnRH antagonist ovarian stimulation, triggering with a bolus of GnRH agonist, vitrification either of all oocytes or all embryos, and then frozen embryo transfer, deferred embryo transfer. And the SWOT analysis of this strategy, you will see that the strength of this strategy is increased maternal safety by reducing, and you can have an OHSS-free clinic. You will improve pregnancy rates. You will reduce ectopic pregnancy rates and better obstetrical and perinatal outcomes. The weaknesses is the evidence that there are only 3 randomized controlled trials proving the benefits of this strategy, and some cases of ovarian IHSS hyperstimulation have been published even with this GnRH agonist trigger. The threats is there is a change in our current practice in IVF. Cryopreservation should be optimized, regardless you are freezing oocytes or embryos. There is a cost increment, and also there is a supposed risk in the number of babies with large babies for gestational age. And the opportunities are that more oocytes can be retrieved because you can push the ovarian stimulation a little bit further. You can schedule the embryo transfer chronology. Stimulation can start any day of the cycle and is really a friendly protocol for patients. We hear some data from our group in patients at risk of ovarian hyperstimulation in which these were oocyte vitrification. We, in these cases now, we vitrify embryos and not oocytes. Here we have the experience with 112 patients, young patients, 33 years of age as a mean, warm oocytes per patient 15, survival rate after warming 82%, the fertilization rate after warming was 68%, and 76% of the patients had embryos frozen. And the clinical results, the number of frozen embryo transfer or deferred embryo transfer, all the patients had an embryo transfer. Mean number of embryos transferred 1.7. Clinical pregnancy rate per transfer 48%, implantation 38%, with the twin pregnancy rate too high, 33.3%. And if we consider that these patients could also benefit from freezing surplus embryos, and they can also benefit from extra frozen cycles, here we have had 54 frozen cycles. The mean number of embryos thawed 2.3, survival rate after thawing 77%, and clinical pregnancy rate in this frozen cycle 46%, and the cumulative pregnancy rate 70%. So for us is a clear benefit. For sure in terms of patient safety, because we will reduce the risk of OHSS, and we have to discuss if this is a strategy that can be used as a routine for normal patients. If you compare the concept of cumulative pregnancy rate, I mean fresh plus frozen cycles, you will see that after 2-3 cycles you reach almost around 70% of pregnancy rate. This is a publication by Anna Pia Ferraretti in Bologna with a very soft protocol combining clomifen plus low dose of gonadotropins and very friendly monitoring. And as you can see here, with 3 cycles, almost 70% cumulative pregnancy rate, which is an excellent result. And the final strategy that you can propose to patients with poor response is to offer them the possibility of a natural cycle before switching to oocyte donation. And here are the results published from by Iñaki González from our group, in which he presents the results obtained in natural cycle in 3 different age categories for poor responders: younger than 35, 36, 39, and over 40. And you will see that the pregnancy rate per cycle remained more or less stable, around 11% per cycle, which is low, but is the last hope for these patients. But when the patient is over 40, the pregnancy rate is only 5.9%. There is a significant reduction. The same happened with pregnancy rate per transfer. Of course, the miscarriage rate significantly increases according to the age of the patient, and the ongoing pregnancy rate is valid, but in patients over 40 is, in our opinion, is useless to propose them an IVF cycle with a natural cycle with their own oocytes. In conclusion, the evaluation of ovarian reserve is crucial because you have to identify which type of patient you have in front of you. Ovarian reserve markers are useful to predict future ovarian response of these patients. The best markers, in our opinion, are age, of course, but AMH and antral follicle count. And be careful because some young patients can present contradictory AMH levels and very low AMH level, and they respond afterwards normally. There are new strategies that can be used, the use of growth hormone, intravariant androgenization, even by giving oral androgens or transdermal androgens, luteal phase double stimulation, and this is a strategy that the protocol called, you will see in the literature, as duo-stim or duplex for low responders. And of course, the improvements in IVF labs thanks to the quality of oocyte and embryo vitrification, the possibility of accumulating oocytes and embryos, the use of time-lapse methodology to improve embryo evaluation. And in the end, you will have to decide between this individualized versus conventional ovarian stimulation. And in a multi-center study we were involved, the clinical conclusions were that you can adapt, you can individualize, you can tailor the strategy based on AMH, age and body weight of the patient, and this will result in similar ongoing pregnancy rate, ongoing implantation rate, and live birth rate. You will have more patients with target response, more optimal responder. You will reduce the number of suboptimal, and you will have less gonadotropin requirements, low number of patients with low response, low number of patients with excessive response, and a reduction in the need for OHSS strategies prevention. I thank you very much for your attention, and we can now open the issue for discussion.